Hi, good morning, everyone. Uh, we are live on 158th weekly session for CMAAO International Meeting. And we are meeting over here for another topic on diabetes. We have Dr. Abhyuday Verma. He's a diabetic expert. The topic is diabetic awareness and prevention. Dr. Abhyuday Verma is a professor, associate professor in endocrinology. He's a teacher and guide, DM Endocrinology, Department of Endocrinology, Index Medical College, PG Institute, Indore, Lahore. He's a director at SEVA, Super Specialty Endocrinology and Women Care Center. He's a consultant endocrinology in Verma Hospital in Indore. He's an ex-professor of medicine in Index Medical College. He has over 35 publications in national and international index journals. He is a reviewer of 6 national and 4 international journals of diabetic, obesity, gynecology, child health, nutrition, and extra, and moreover, he's a recipient of 2021 Charak Award, IMA, and he's a facilitator on the Teachers' Day for the Ministry of Culture and Government of India. He's a recipient of MP Bhushan Award by Padma Shri Dr. Vijay Shah. Sir, over to you.
Thank you for your kind words, Saurabh-ji, and good morning, everybody. At the outset, I like to thank the Heart Care Foundation of India for giving me this opportunity to speak, or rather, I would say to spread the awareness of diabetes, which has become a global pandemic. And I would say rather, it's not only diabetes now, we would, or we can call it a diabesity also, because it's like the both diabetes and the obesity pandemic are going together hand in hand. So the main purpose, I think, we are all here to discuss how we can spread the awareness of diabetes and work for the prevention of type 2 diabetes mellitus. And as we all know, according to these IDF data, we have the data which show that the prevalence of type 2 diabetes mellitus has increased dramatically in countries of all income levels. So I think we all are quite learned people here. We all know earlier we used to feel that this is a disease of a country where we have surplus amount of food consumption, but now all the data across the globe has shown that countries of all income level, including the countries which were thought to be in a starving state, they have also joined this pandemic. In 2021, we had almost 537 million adults between the age of 20 to 79 years living with type 2 diabetes mellitus across the globe, which constituted about 9.3% of the total population. So you can see almost 1/10 of our total global population is suffering from type 2 diabetes mellitus. And we also know that equal number of patients are undiagnosed also. So we can think that every 1 in 5 or 6 person we meet is or would be suffering from diabetes. And the latest data show that the highest comparative diabetes prevalence rates were reported in Pakistan to the tune of 30.8%. So imagine here it is 1 in 3 person suffering from diabetes. French Polynesia 25.2%, Kuwait 24.9%. So you can see that how the diabetes pandemic has blown out of proportion in these countries. And the prediction, the predicted prevalence of diabetes from 537 million in 2021 may cross 643 millions by 2030, 783 million by 2045, and 1.3 billion by 2050. If we continue with the same rate of the pandemic. So I feel it is our duty as responsible physicians and doctors to spread the awareness about diabetes and its complication, and more important, we should go for the prevention of diabetes, and this should be spread to all the countries across the globe and to all strata or economic condition of patients. As I was talking about undiagnosed diabetic patients, it consists of people or population who have pre-diabetes also. And this is again a very important group of people where we should try to intervene to prevent the progression of this population from a pre-diabetic or a borderline diabetic state to overt diabetes. And if we are able to stop or halt this progress, we can definitely improve the conditions of our people. We can prevent them from diabetes related complications. So this is a small data again from the IDF, which shows that pre-diabetes between 2017 and 2020 data shows that we had about 19 million people with pre-diabetes across the globe, which increased to 97.6 million. So you can see, I think, almost 5 times increase in the population of pre-diabetes. So you can imagine that how this from normal glycemic level patients have jumped to a pre-diabetes level within a span of just 4 to 5 years. Maybe it may be due to the more awareness or more active investigation of the routine population, but still this is quite alarming. And if we break this according to the age of the population, between 18 to 44 years age adults, we had 13.8 million with pre-diabetes in 2017, which almost tripled to 32.8 million in next 4 to 5 years. And same is the story between 45 to 64, which almost doubled in these 4 to 5 years. But again, you see that the main age group is the young population, which is coming in the grip of this pre-diabetes, and these young individuals would be are people who will have maximum risk of getting overt diabetes in future, and we should be targeting these young individuals so that we can prevent the progression and take care of their overall health. And this is our motto. So what is basically type 2 diabetes mellitus? We all know it is hyperglycemia, uncontrolled blood sugar levels, along with insulin resistance and impaired insulin secretion, which again, according to different population, different ethnicities, have a different presentations. Like maybe in Asians, we may have more insulin resistance and impairment in insulin secretion, which comes at a quite early age, maybe a decade earlier compared to the Caucasian population. Then we have more of the central adiposity, which leads to more insulin resistance. These special phenotypes of Asian diabetics make them more prone for developing diabetes, and along with that, more complications also compared to the Caucasian population. So seeing these parameters or this phenotype, the lifetime risk of diabetes is quite high in certain ethnicities. But the prediction is quite challenging. So this is a problem. A lot of patients, they ask us that yes, if it is confirmed that they will have a diabetes, so sometimes we are in a fix that yes, we may say that you are at increased risk of diabetes, but not sure that definitely you'll develop a diabetes. This makes them less serious, maybe, or maybe healthcare workers also become less serious because the prediction is quite challenging. It depends on the atmosphere, their lifestyle, their uh, their family history. All these things make this prediction of getting diabetes or progression from pre-diabetes to diabetes very difficult. But yes, we should be targeting some special subset of population where we need an aggressive approach. And these high risk individuals are the people who have impaired fasting glucose levels, which is between 100 to 125 mg per deciliter. Then the impaired glucose tolerance, where we have the blood sugar levels between 140 to 199 mg per deciliter. Obese individuals, especially having the central adiposity. Then the close relatives of type 2 diabetic patients, and obviously members of certain ethnicities where the risk of developing diabetes is quite high, as the Asians, Africans we have. And we should also be choosing appropriate candidates for preventive interventions. So this is very important. I won't be talking about the treatment today, not much about the drug therapy, pharmacotherapy, but the prevention, because prevention, we feel that it is the key to stop or slow down this whole pandemic. Obviously, the genetic risk factors for type 2 diabetes mellitus been identified, but again, the polygenic risk scores may enhance traditional demographic and clinical risk factors stratification in future. Yes, we may know more details, more future predictions with the advancing science. But then again, the traditional risk factors for type 2 diabetes mellitus remains same. And I think our approach also would remain same even if we know more details about the pathophysiology of type 2 diabetes mellitus. And these approach for prevention I would be highlighting today. So what are the goals of diabetes prevention? What should be our aim when we talk or when we try to create awareness about diabetes and try to create a mass awareness amongst our colleague and general population? It should be about diabetes prevention. How we can do that? By preventing or delaying the onset of diabetes, by preserving the beta cell function. We know in type 2 diabetes mellitus there is a gradual destruction or decline in the beta cell function. So we should try to preserve the beta cell functions. Then if somebody has got diabetes or even pre-diabetes also, we should try to prevent or delay microvascular and cardiovascular complications, because studies have shown that the cardiovascular complications and other complications, they start years before the onset of full-blown diabetes. So maybe in a pre-diabetic state, 4 to 6 years before the diagnosis of over diabetes, patient is already at risk of these complications. So our aim should be to prevent or delay these complications also. And ultimately, we all know diabetes and its complications, treatment, management is quite costly. So ultimate aim also comes to reduce the cost of diabetes care. So I think this should be our goal when we talk about the diabetes prevention. And amongst these, a lot of studies, data analysis have shown that beta cell preservation holds the most important role, as it may prevent the transition from pre-diabetic state to a full-blown diabetes. So our aim when we talk about diabetes prevention or progression from pre-diabetes to diabetes should be targeted beta cell preservation. Our approach should be for beta cell preservation. And what the ADA guidelines tell us, that who are these high-risk individuals, where or in whom we should target to prevent the progression from pre-diabetes to diabetes: adults above age of 45 years, females with a history of gestational diabetes mellitus, or adults of any age if they have a BMI more than 25 kg per meter square, along with one or more of these risk factors. A family history in first degree relative of type 2 diabetes mellitus. Again, the high risk ethnicities, sedentary lifestyle, patient with history of hypertension or on treatment for hypertension, patients with dyslipidemia, patients with history of cardiovascular disease, females history of polycystic ovary syndrome or who are undergoing treatment for PCOS. So these are the high risk individuals where we should target for the diabetes prevention. And at any age, if you have a higher BMI, more than 25, or even when we talk about the Indian or Asian population, I would rather say more than 23 kg per meter square BMI with any of these one or more risk factors, we should be targeting the patient for diabetes prevention. We should not wait for the blood sugar levels to come in a higher range. We should be targeting. If we see them in our routine clinical practice also, if they have come or presented it to us for some other conditions, some other disease, some other problem, if we see any individuals, our approach should be for diabetes prevention also in these disease, because they are at high risk of developing type 2 diabetes mellitus in future. And obviously we can do it easily nowadays by taking a HbA1c percentage or a fasting plasma glucose. OGTT was done earlier, but now as a lot of people or guidelines feel that this is a bit cumbersome, so yes, still holds a very important role, but then again, due to the convenience, ADA says that HbA1c or a fasting plasma glucose level is quite okay when we want to identify these individuals. So these are some of the recommendations according to the blood sugar levels. The fasting sugar more than 126 or HbA1c more than 6.5. First time in any individual, reconfirm it, maybe after 2 weeks or so, and then start the treatment of diabetes according to the patient's risk factors. You may start somebody only on a kind of weight reduction therapy if you feel that the person is young and the weight loss will help in taking care of the blood sugar levels. Definitely we can try for a couple of months with weight loss therapy. If the sugars are not well controlled even after weight loss, then we may start. Or if somebody is at a very high risk of getting a cardiac or renal comorbidity, then definitely we should start him or her on the anti-diabetic therapy as soon as the diagnosis is made. So it should be individualized. Individualized approach, we all know that nowadays is the key factor where we should individualize the therapy and treat accordingly. Then when we have a fasting plasma glucose between 100 to 125 or A1C between 5.7 to 6.4% or a pre-diabetic state, we need again to reconfirm it and then promote lifestyle changes and regular follow-ups are required, maybe annually, maybe every 6 months, maybe quarterly also, according to again the individual's risk factor. And this, I think, we should be taking care seriously about this group of patients who are in a pre-diabetic state or a borderline diabetes. And lot junk we know about these pre-diabetics across the globe is there, and we should prevent them from progressing to overt diabetes. If the fasting blood sugar levels is less than 100 mg per deciliter or A1C less than 5.7, retest high-risk individuals 2 or 3 years later, or again as and when required according to the patient's risk condition. And OGTT also, yes, but now it is seldomly used, but it's a very good tool. We can do it as and when required. Now coming to the prevention, how other than pharmacotherapy, we can help our patients to live better with diabetes, or to help our pre-diabetics to halt the progression to over diabetes. Only pharmacotherapy would not help, we all know. We have been using n number of medicines, OHAs from our armamentarium, but we know that until unless the patient goes for a good lifestyle modification, he or she would not have the sugars well controlled below the target, and would not help in reducing the micro and macrovascular complications. So all patients who are in a pre-diabetic state should have a regular counseling and follow-ups regularly for behavior modifications, the dietary therapy, physical activity counseling, and smoking cessation. And this is all should help our patients to lose weight. So again, the major importance, the major risk factor, as I told in the beginning, the obesity and diabetes pandemic, the diabetes pandemic is going hand in hand. So if with all these modifications we are able to reduce the weight of our patients, definitely we can make them normal back again. And then obviously we should assess the response to lifestyle intervention also as and when required. Especially, again, I would re-emphasize high risk patients, age more than 60 years, BMI more than 35, history of GDM. And if there is no response to lifestyle, then we can add metformin also in these patients. According to the DPP trial, the diabetes prevention program, I won't go in detail of this because of the paucity of time, but we all know it's a landmark study and has shown that yes, along with lifestyle, if we add metformin to these high risk individuals, we get a good response compared to the only lifestyle therapy. And although in this study, elderlies were less responsive to metformin therapy. And without medication, if we feel that our patients are doing well, the blood sugar levels are getting towards normal, patients are losing weight, we can keep a good follow-up, continue diet and exercise with a regular repetition of laboratory. When we talk about efficacy, a lot of people, they argue, they say that lifestyle interventions are not good. But then again, we know that yes, it may be difficult for people to sustain a lifestyle change for a longer duration of time. But then again, a regular follow-up, regular counseling of patients can help our patients stay away from full-blown diabetes without help of pharmacotherapy. As a lot of meta-analyses have shown that beneficial effects of lifestyle modifications, they persist for years after stopping those modifications also. Finnish diabetes prevention study, which had about 522 middle-aged individuals with impaired glucose tolerance, and a BMI of about 33.2 showed that with exercise and diet, there was a significantly lower risk of developing diabetes, which was to the tune of 11 versus 23%. And the benefits persisted 3 years after the end of study also. And in the extended 7 years follow-up of this same DPP-4, it showed that diabetes incidence was just 23% versus 38% in the standard therapy. So here you can see the beneficial effects persisting even after the patient has stopped the intensive lifestyle modification also. Again, talking few words about the diabetes prevention program. Intensive, we had lesser patients. They showed that even 1 kg weight loss reduces the risk of developing diabetes to the tune of about 16%. Females with history of GDM, similar benefits with the use of metformin and lifestyle intervention was seen. And then the DPP outcomes trial again showed that benefits of lifestyle intervention persisted for 10 years and then again reanalyzed after 5 years. 15 years of the whole therapy showed that these intensive lifestyle changes, they have immediate and a long-term benefit. Along with these modifications, we know that exercise also should be an integral part of our whole prevention. It is advised in high-risk individuals that about 30 to 60 minutes of moderate intensity aerobic activity on most of the days of week are preferred. It should be at least 150 minutes per week. And various meta-analyses have shown that there is a lower incidence of developing type 2 diabetes mellitus if an individual goes for a moderate physical activity, like even a brisk walking for 150 minutes a week. It can significantly reduce the risk of developing type 2 diabetes mellitus. And data also showed that greatest benefit in males, young and middle-aged, greatest benefit was seen with aerobic and weight training exercises also. So yes, we want to target these age group individuals. We should advise, counsel them for aerobic and a moderate weight training exercise also. Diet, yes, lot of things, lot of fat diets are available nowadays, but no consistent data is available with all these fat diets available nowadays. But two very important, according to me, the dietary patterns, the DASH and Mediterranean diet, have shown consistent better results in reducing the risk of diabetes and reducing the risk of cardiovascular complications also. But yes, the data also emphasize that we should not be focusing on any specific nutrient. The diet should be flexible diet according to the local preference, the patient's routine, the patient's comorbidity, so that we can have a long-term adherence of these dietary benefits. As a lot of diets, they advise fruits, vegetables, whole grains, beans, nuts, seeds should be taken in large quantity. Low to moderate amount of fish, poultry and dairy products are also advisable. More than this, I won't go in details of diet. Then smoking is again a very important risk factors. Several large prospective observational studies have shown that smoking increases the risk of developing type 2 diabetes mellitus because it provides a milieu of chronic inflammation. And studies have also shown that smoking cessation help reduce the inflammation. So reduction in development of type 2 diabetes mellitus and various complications. But few studies or data have shown that after smoking cessation, some people they tend to gain weight, and this might again increase the risk of developing diabetes because of obesity. So we have to advise or counsel them after cessation of smoking about a regular dietary and exercise schedule. Coming to pharmacology, therapy again advised in high risk individual in whom lifestyle intervention fail or are not sustainable. Long-term benefits and cost effectiveness of early pharmacological treatment are still unproven. We have no good solid evidence, but yes, we have a lot of data. In high-risk individuals, metformin for diabetes prevention is usually advised. 850 mg once daily for 1 month, and if patient tolerates, we can go for 850 mg twice daily. This is approved in many countries, but is off-label in US. Again, individuals with IFG, IGT, A1C in the prediabetes range and patients who require a anti-obesity treatment, we may prescribe semaglutide for treatment of obesity, which will reduce the risk of progression to type 2 diabetes mellitus. So it may delay or prevent the diabetes onset. Step 1 trial has shown that with the use of semaglutide, there was lower frequency of progression to frank diabetes versus placebo. But again, these are only few studies or very little data. Long-term benefits are still not known with this drug. And there are n number of drugs which have been tried to halt the progression to over diabetes and weight loss also, but the data are inconsistent. Like insulin, early use of insulin in pre-diabetics may preserve beta cell functions. Liraglutide, lot of cardiovascular benefits and weight loss with this drug, but still data are inconsistent. Pioglitazone, rosiglitazone, again the controversy of weight gain with this, heart failure chances with this, so not really approved or recommended. Orlistat, way for weight reduction. Alpha glucosidase inhibitors, vitamin D, SGLT2 inhibitors, again seeing their cardiorenal benefits and weight loss. Some data, inconsistent results have shown that they may also help in these pre-diabetic patients for diabetes prevention. ACE inhibitor, ARBs, they improve the insulin sensitivity. So some studies have shown that they may halt the progression. And last, about few words about bariatric surgery. We all know that with bariatric surgery, various procedures, I won't go in detail, there is a large degree of sustained weight loss and a large improvement in glycemia. A lot of our diabetic patients, they are off insulin, they are even off OHAs also after the bariatric surgery. But again, there is a very less data available evaluating the ability of this bariatric surgery to prevent diabetes. And this has been seen in a lot of non-randomized trials from Sweden when bariatric surgery was compared to the usual care. But yes, we know bariatric surgery helps in weight reduction. So long-term, lesser subjects are known to progress from a pre-diabetic state to diabetes after surgery, because along with weight loss there is improvement in insulin sensitivity and a improvement in beta cell function also seen in post bariatric surgery patients. So I think I would end my talk here. The basic, we all know that when we want to talk about diabetes prevention, we have to target high-risk individuals and counsel them for lifestyle modifications, and regular follow-ups, regular counseling, regular laboratory tests are required to prevent the diabetes progression. Thank you.
Thank you, Dr. Verma, for enlightening us for very, very important topic. I think this is a need of an hour. Rightly said that a lot of people in the world, not only in India and Pakistan, are suffering from pre-diabetes and diabetes. So I would like to open this forum for question answers, and I would like to invite Dr. Chong, the chair of the CMAAO, to take it forward.
Thank you, Sarab. And thank you, Dr. Abhyuday Verma. Thank you very much for your very enlightening talk. I joined a bit late, but I got a gist of what you said. And it is indeed true that it's an epidemic of diabetes globally. Even in Singapore now, it's about 11% of our population are diabetic. So that's below at 30, 1 in 5, at 60 years old, 1 in 3 in Singapore. So this is a real challenge for us, this massive tsunami of chronic diseases, and fascinating, as always, to look at the latest data on prevention of diabetes, because that's really a war that we don't seem to be winning at all. I'd like to open the floor to the floor. Any questions for Dr. Verma?
Dr. Chong.
Yes, Dr. Sajak. Yes, please.
Good morning, everybody. I hope everybody is perfect and energetic. I think so. So, a fantastic presentation by.
Thank you, sir.
Actually, you have touched everything which is very important for everybody who are suffering from the diabetes or not. But my concern is that I belong to a Pakistan Medical Association, and we have a slogan that prevention is better than cure. So we are here sharing this slogan to everybody. We spread this slogan to everywhere. So people should go for the prevention even rather than to go for curation or curative side. So my question is to you that what is the upper limit of the blood fasting, which we can say that you are now the pre-diabetic or now the diabetic, and the limit which the one can start the anti-diabetic, diabetic drugs, for diabetic drugs. Secondly, what do you suggest that people are saying that the bakery items and the junk foods, rather, which is very much common nowadays, and the people, particularly the young generation are going obese and obese and obese. So, what is the role of this junk food for people developing obesity and having the diabetes mellitus? Thank you very much.
Thank you, sir. And I think very practical questions you have asked, what we or the whole society is facing nowadays. So first, I would talk about the blood glucose levels. I think, especially in our Asian population, we should be really strict when we should not we are not supposed to be liberal as a Caucasian population. So we say when we see a person or individual with high risk, maybe slightly on a overweight side or a family history, or maybe a hypertensive patient coming to us with the routine investigations, if we see the fasting blood sugar levels between 100 to 125 mg per deciliter, we should activate our antennae. We should treat, or at least I would say counsel regularly these patients for lifestyle modifications. Some guidelines, they say even in pre-diabetes who are at high risk of developing diabetes in future, along with the risk factors, should be started on a pharmacotherapy, which can delay the progression, which may improve the beta cell functions, and would help in weight loss. And as I have mentioned in my slides, that a lot of studies have shown that exercise, diet, and weight loss has helped a lot in reducing the incidence of diabetes and reducing the progression from pre-diabetes to diabetes. But amongst them, most of the study, they say that weight loss is the most important factor. So coming to your second question again, I would repeat the same thing, that the junk foods, they basically are calorie rich foods. You talk about the pizza, burgers, the aerated drinks also. So these we all know this Western diet, and especially in the this part of our continent, whether it's India, Pakistan, whether it's Malaysia, Indonesia, Singapore, we are our genetic susceptibility for developing diabetes is quite high. And these are kind of non-traditional food for us, which are not made perfectly according to our lifestyle and our environmental factors. So these fad foods should be avoided. We should definitely across the globe, or especially in our Asian countries, we should be like how you do in PMA. You have gone for the prevention better than cure. We should try to spread all these things across, especially in the younger individuals starting from the school days.
Thank you very much. One thing I would like to know, the people are saying that the brown breads, it's better to reduce the sugar level, or any breads instead of taking the roti. We in Eastern people are taking roti. So what is your opinion, that it is preferable that brown breads, or and the substitute of the sugar, the what you call as stevia or something with the name of stevia instead of sugar. So it is recommended from your side, or it is better, or it has their own side effects?
Yes, sir. Again, a very good practical point raised here, sir. I would, sir, I'm a bit orthodox person regarding diet. I would say I still don't prefer any kind of bread, whether it's a brown bread or a white bread. Now, see, sir, according to, again, I would go to our traditions. We have so many varieties of our if we say bread, whether you say it's a roti, whether you say it's a naan, whether you say it's a kubas, anything. See, we have all these traditional food patterns which are made for our individual population since a long time. And these, so I won't say, yes, a lot of people, a lot of dietitians, they say, oh, the brown bread is better, the the multi-grain bread is better. But I
Yes.
usually tell my patients to avoid as much as possible. And then when we talk about, sir, what was your next question about?
The substitute of the sugar.
Substitute, yes, sir. See, again, sir, I am again totally against these substitutes. This is my individual perception. And data are available, but this is my individual perception. I usually don't recommend any kind of these artificial sweeteners. I say yes, if we have festivals, if we have some special occasions at home, yes, you may use it occasionally as a substitute for sugar. But no, I say, see, this is a chronic disease, a lifelong disease. And if somebody stays away from sugar totally for a smaller duration of time, for a couple of months, I think that they won't require sugar at all. So it becomes a habit. So I feel this is my personal preference. If the house can have some more light on this, their personal experiences, you can share with me.
So, Dr. Verma, I would like to add something over here, which I know and have a personal experience. One, there's a clarification that brown bread is not a wheat bread. There are three categories of bread. Brown is just a color in white flour bread, which is called maida, and maida is not good for health. So if you go, it's a white bread and a brown bread. They're just same with the color in the bread, and then we call it as a wheat bread or a different flour bread. So that is one clarification. Second, I think what I remember Dr. KK used to say, that any form of refine is bad for health. There is no substitute of sugar, but if you can go and take jaggery, if you can go and take sugar, it is not advisable, but again, it is better than what you are taking. So you should go in one form of your health in a way where you should go towards nature. The better it comes through a nature, the better it is for your health. If you can completely avoid, it is completely good, but a lot of people cannot avoid. And if you say that you are taking, let's say, 3 cups of tea or 4 cups of tea and you are having 4 teaspoons of sugar, then you should go in a form of natural sugar, which could be good, or which comes out directly from sugarcane, which could be jaggery in a different form, which call it sugar. So it's a chain. So sugarcane gives good, then it comes jaggery, then it comes shakkar, then it comes sugar. So it is a refined form. This goes with the oil itself also. So the more you go towards nature, the better it is for you.
So, Dr.
Prof.
Verma,
Ashraf?
you mean,
Sorry.
I'm sorry, Dr. Chong, just I would like to know, you prefer the what we Eastern eat roti with the other dishes with roti, so you prefer roti instead of the this breads and what in the marketed brown breads, or this you prefer roti?
Sir, as per the new initiative by WHO, I prefer my patients more of millets nowadays, like
Millets,
jowar
absolutely.
we have.
Sorry?
Like jowar bajra we have available
Yes.
now, as
Yes.
WHO has um, uh, talked about millet use more. So I am recommending more of millets. And I see individually, I have seen in our institute also, in my practice also, that yes, using millets, jowar or bajra definitely helps. Again, I would say there is a small means, maybe my perception, I would say, that wheat is not made for our continent. This I am very this thing, we are not basically wheat eaters. गेहूं का हमारे उसमें it's not a role. Definitely our main staple diet is maybe rice, jowar or bajra. So I think if we use and recommend more to our patients, we may get a better health and a better glycemic control, other than using the wheat based, maybe atta, maybe rava, maida, whatever. So we should avoid these.
Also, Dr. Sajad, just to
Abhi-
answer your question, whatever
yes.
is freshly cooked is advisable. So breads and everything has a very long time of chain, when from the factory, when it is cooked and to your place. So I think
Yeah.
whatever is freshly cooked is advisable. So if roti, whatever you say, the chapati, whatever form, it is like wheat or millet is what Dr. Verma has said, it is advisable. And whatever is freshly cooked, that is more better for the health rather than something
Good.
which has a long chain and has a lot of preservatives in it.
Excellent.
Prof.
Excellent.
Ashraf?
Thank you very much, Dr. Verma and Agarwal. Thank you. Saurabh.
Yeah, thank you, Dr. Sajad. Prof. Ashraf, you have a question?
Yeah, thank you very much, Dr. Chong. Good to see everybody. Dr. Verma, thank you very much for a wonderful talk. And hence, that 14th November, globally, we were talking about the diabetes, about the prevention, about the treatment, and so on. Indeed, your talk is wonderful as far as I consider the prevention and the concern of advisory. My question is very simple, just to ask as a diabetes specialist from you, that is it a reversible disease or not? This is my question. And secondly, about the chapati and wheat, what has been said by you, that this is not for our region, I mean the subcontinent. I want to share, it depends upon, Verma, where you live. If you live in Bengal, definitely you are with the fish and the rice. If you are in the part of some sort of India where the rice is. But hence, I am from Punjab, and without wheat, it is, life is nothing. What we have the perception over here, just on a lighter mode. Thank you very much. But my question remains only the
Yes.
single, that is whether it is a reversible or not. Thank you.
Thank you, sir. Very valid. Yes, definitely a lot of patients, even we get a lot of wheat eaters or wheat-based food eaters at my place. But yes, wheat is an integral part, definitely. But of late, it is seen that, okay, we may use wheat, but then again, if we can increase the use of millets in our diet, that would be helpful for. No, it's not that we would be asking our patients to avoid wheat, but we can always say कि if you are taking roti, तो ठीक है, एक time you can make millet roti or something of like in Rajasthan they have khichda of the jowar bajra, like that. So we can, means we should try to incorporate millets also in diet. It's not like again changing the tradition from wheat to jowar or bajra. So yes, and then the most important thing which you have raised is the reversal of diabetes. Yes, there is everywhere across the globe, lot of people, lot of advertisements about the diabetes reversal is going. And yes, in a way it can be done also. Maybe not exactly a diabetes reversal, maybe a diabetes remission, I would say, precisely. Because see, in a freshly diagnosed diabetic person, if we go with the beta cell preservation, dietary lifestyle modifications, the weight loss, the proper diet, the proper exercise, yes, data has shown that these people can go in a remission, a long-term remission, a short-term remission, or maybe a permanent remission also is possible. But it depends again on the individual, the beta cell reserve, what they have, their genetic or the family history, their comorbidities, these all, they all decide that whether the person can go in reversal or remission. So yes, we should try. I have a lot of data, these patients were in post-COVID era, they received a lot of steroids. Maybe they were pre-diabetic. They had a very high blood sugar levels. We went for initial insulin therapy, then brought them down to only OHAs, especially which were non-insulin dependent anti-hyperglycemics like SGLT2 inhibitors and the DPP4 inhibitors. And we were able to reverse or maybe a remission of diabetes in almost 50% of these individuals. So yes, it is possible in a certain group of patients, and I would advise that definitely we should try for all our patients. है ना? हो सकता है we may not get a total reversal, but at least अगर शुगर अच्छे से कंट्रोल, diabetes gets better, we can prevent their lot of micro and macrovascular complications.
Thank you, Dr. Verma. May I have something to say? In my practice and in my country, our problem is fascinating to hear the kind of different wheats and foods that you're eating. But in my country, it's white rice, polished white rice, which is a disaster. And 250 grams of white rice is about 75 grams of sugar. So that's 15 spoons of sugar. And the absorption is glycemic index is 98. So 100 is sugar syrup. So eating a bowl of white rice is 15 spoons of sugar in a syrup equivalent. And as a result, but interestingly, if you look at 100 milligrams per deciliter, which is the normal fasting sugar, actually, we only have 5 liters of blood. So that's 1 gram per liter. That's only 5 grams of sugar in our blood. And we're eating 75 grams. So this is actually the biggest challenge we have in my country. You know, two meals of white rice a day, 150 grams of sugar at super high absorption speed, spikes the sugar, the pancreas goes into overdrive, secretes more insulin. The insulin drives the visceral fat. And then the visceral fat is the mother of all evils, the cytokines, the hormones released. So really, in my country, our biggest enemy is white rice, polished white rice. And trying to get people to change to other forms of staples is so difficult. And that's our challenge here in Singapore.
It is worthwhile to listen to Dr. Monica coming from a country where there are a lot of cheese and fast food to be eaten. So I still remember going to US and I got this big coffee cup and I said, this is like my 5 coffees.
Well, okay. I wasn't going to start with that, but you know, filling up your stomach with fluids and water-filled foods, fresh fruits, fresh vegetables, things that are not dense is going to make you feel fuller faster. And it's a 2-pronged approach. 1 is reduced calorie intake, and 2 is utilizing foods that have high fiber so that you are not raising your glycemic index, eating slower, and addressing all the food myths and stories and behavioral patterns and social attitudes that go towards how you approach your meal. But I want to say this is such an important topic for all of us. It's coming from the Indian diaspora in all over the world. We know that Indians, or in our diaspora, that we are at a higher risk for having diabetes. I was diagnosed with gestational diabetes when I was with my first pregnancy. And my endocrinologist said to me, she said, I would have never predicted that with your BMI that you would have had failed your oral glucose challenge test based on the demographics. And there is something about your genetic background that makes you have these outcomes. And we see it everywhere. So we are at higher risk. So we need to talk about this more. We need to make it more acceptable to make these changes, to change our wheat sources to millet. We have to kind of move away from where I think our culture of food just needs to change. So that was my first concept. My second thing I wanted to say is, like any other chronic medical condition, and this requires high motivation from not only the patient and their family, but also the relationship between the patient and their doctor or whoever's managing their diabetes, whether it be a nutritional specialist, whether it be anyone, because it is going to have days when it works and there's going to be days that it's not going to work, and you need constant positive reinforcement. So Dr. Verma, thank you for what you do, because you probably have very long relationships with not only the person who you're treating, but their entire family, multi-generational extended family, and their kitchen. So thank you for what you do and bringing this all to light.
One quick question we have, and we'll end up session after that. We have seen a lot of pre-diabetes and early diabetes in the youngsters, especially the kind of food and hereditary. So which is more problem, hereditary or the food? That is like one question. And the second question is that what are the symptoms that the parent should see on the early diabetes? When we talk about early diabetes, we are talking about early 30s, or in fact, before 30 also. What are the symptoms we should notice for a person to go and do a checkup? Because usually it is very painful for getting kids to go and get your blood sugar test done and everything. So what are the symptoms people should see, and what is it that early precautions, and is adding bitterness to your food helps?
Yes, yes, Saurabhji, very, very valid and practical points. This we need to spread the awareness. Yes, the main what want is diabetes prevention, and as an Indian or a Asian population, we are all at risk of developing diabetes anytime in our life. So it's like we should start it as early as possible. If they are not even adults, if you see a kid having a disturbed lifestyle, sedentary habits, maybe acanthosis, the blackish discoloration, nape of neck, and you see that they have a disturbed lifestyle, definitely I would advise that not maybe annually, but at least they should get their routine investigation. It's not only about the blood sugar levels. A lot of kids, adolescents are having high blood pressure, dyslipidemia also. So I think these all should be checked in these high risk individuals. I would say definitely above age of 30 annually, the checking, especially in our country, should be done regularly. But in high risk individuals, as in my talk I have told, BMI more than 23 with the risk factors we should go for. Now, we should not wait for the full-blown signs or symptoms to develop. It should be a very proactive approach. We have to be very, see, if we want to slow down this epidemic, if we want to prevent diabetes, we have to be aggressive in prevention. We can't just wait for the things to develop and wait. So it's like when we see any overweight individual with high risk of developing diabetes, we should advise them, we should counsel them for regular checkups.
Thank you, Dr. Verma. That was a very enlightening session today. And if there are no more questions from the floor, I think we'll call it a day to this session. But in fact, I think this is really one of the most important topics for any health community in any country, from health minister down to everybody else. I mean, in Singapore, we declared a war on diabetes 3 to 4 years ago. And I must tell you that we're losing the war. So, it's quite sad.
Dr. Chong, the problem is not, I think, the food. The problem is also the starting of the pillars. If you go, I was very surprised to see the school menu box.
Yeah.
The school.
Yes.
People, so I saw that there was pasta, there was noodles, and there was no diet food. There was no proper food. It was like, you have to bring pasta today. I was like, if you're teaching the kid in the school to eat pastas and all those junk food, then you are building a good pillar for diabetes.
Actually, Sarab, pasta actually has a much lower glycemic index than white rice, about half. It's about 40 to 50. I mean, it must be Italian pasta. It must be the original durum wheat pasta. But there are a lot of fake pastas, a lot of fake.
And the kind of oil being used in it, the kind of I think more of the pasta. I think the kind of add-ons. What is the problem?
Yeah. So. But there's a huge challenge because even when you buy so-called low glycemic index foods, there's a lot of fake low glycemic index foods. So that's also another problem altogether. But anyway, without much further ado, thank you everyone for today's session. Most interesting topic and something very close to all our hearts and always on our minds all the time. You know, this is a massive, massive problem in every country. Thank you very much, Dr. Verma. It was a pleasure listening to you. Thank you everyone for joining today.
Thank you everyone for joining in. We will see you again next week. Thank you.
Thank you. Thank you, Verma. Thank you.
Thank you.